So part of your assessments of your chest tube is ensuring that you have the safety equipment. So the safety equipment has to go with the patient wherever they go. If they go for chest x-ray, it needs to go with them. They never leave anywhere without it. So what's included in that is a bottle of sterile water, Gelinette dressing or a Vaseline impregnated dressing, 2 clamps, 4x4 gauze, and a pair of non-sterile gloves. Sometimes you will see that there might be also tape there. Okay, so what do we do with the sterile water? So, if the chest tube becomes disconnected, let's say it goes like this, what we're worried about is air going into the pleural space. Now, I cannot reattach this right now because this is contaminated. So what I have to do in the meantime is grab my sterile water and quickly put it into the sterile water. What this does is it now maintains the air leak, or it maintains the water seal to ensure that air can escape from the pleural space, but it does not go back in. This is essentially what the Pleur-evac is also doing with the air leak chamber, the water seal chamber that it has. Now, we've solved this. Remember, you're always assessing your patient and their respiratory status and how they're doing, but now what we ultimately need to do is get a new Pleur-evac connected to this, and that would be within the RN scope to do. So we can, as an LPNs, can do this complication deal with it and put it in sterile water, but we need to collaborate now with the nurse to get a new Pleur-evac set up to attach here. Okay. So that's if the chest tube becomes disconnected. Now, if the chest tube falls, this drainage system, it completely falls over, it breaks the water seal, which means that it will no longer ensure that air does not come into the system. So if that happens, again, you need to collaborate with an RN, as only they can do it, and set up a new system that needs to be connected now to the patient. We noticed in the previous video when we did assessments, there was an air leak. So we saw that there was an air leak. This is not within your scope, but let's say this was reattached. I would never reattach this in real life, but this is now attached and we see a number 1 air leak. You have to collaborate with the RN, and they do a system where it's called bunny hopping, where they use these clamps. Again, this is not within LPN scope. And they clamp this off to see if the air leak meter to ensure the bubbles go away. So, for example, if I were to clamp here, and let's say, as an RN, and the air leak chamber, there's no bubbles anymore, that may mean that around the chest tube insertion site is where the air leak was coming from. So what an RN would have to do is cover that area underneath this dressing with a Gelinette. Now, if it didn't stop, then I have to keep moving along the system, which is what the bunny hopping is. If I can get this out. Okay, so I would have to keep moving down. Now, if I clamped it here and it stopped, it could be from this area. As you can see, this is not secured with any tape, so it would need to be. If it stopped, then it's the system. And again, we would continue down and see where potentially the air bubbling stops. Now, if you do the RN does all of that and it does not stop, then it might mean that there's air in the pleural space, and that needs to be reported to the doctor. And always, always assess your patient and their respiratory status. Now, another complication that can happen is the chest tube can become completely dislodged from the thorax. Okay? It's out here. Now we're worried because air can go into the pleural space. So what we have to do in that case is put on our gloves quickly. We probably would ask for some help as well. Open up our Gelonette dressing here. Open up our 4x4 gauze here. That's what it looks like. Grab our gauze here and put this on the site and hold it down, because what the Gelonette, the Vaseline impregnated gauze, does is it allows air to come out, but it doesn't allow air to go in. So what we can do here is watch the patient. Every time they take a deep breath in, we hold it down. When they exhale, we can lift it up so that air can escape. Inhale, close it down, exhale, lift it up. But we also don't have the time to necessarily do that. So what we can do in the meantime is get some tape and seal it down 3 ways. So air can still, again, escape, come out, but does not go back into the system. Okay, that tape's not working. Let's try a different one. So again, 3 ways. So what does that look like? So 1, 2, 3. And of course, we would need to talk to the doctor and report this, that the chest tube has come out. But we would also, before that, report it to the RN. And of course, when we call the doctor, we would be worried that air could have gone in, and we would need orders like a chest x-ray. And again, always make sure that you're watching the patient and their respiratory status. The last complication that can occur is a tension pneumothorax. So what is a tension pneumothorax? So that's when air keeps going into the tube, but it's not able to escape. So what can happen is your blood pressure can drop, your heart rate can drop, and the person is short of breath. You may see a midline trachea diversion, like see a shift. So you have to look at the trachea, and that could mean, and that can happen without a chest tube, but it can also happen with the chest tube. So if the chest tube now was back in and the patient was exhibiting a lot of shortness of breath, you always want to assess the patient and then assess the drainage system and ensure that the patient is not lying on the chest tube and it gets kinked. So when that happens, always make sure, like if the patient is very short of breath, they might be having chest pain, their SATs are dropping, always assess the chest and always assess your chest tube.